Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, it is my honor to welcome to this show Dr. Steffen Decker, an amazing orthodontist who practices in the UK. I'm really looking forward to my conversation with Steffen, as he and I share a passion for early treatment and what orthodontists can do beyond just straightening teeth. And we're going to dive into that and much more in great detail during today's show. But first, to tell you a bit more about Steffen, he completed his dental and orthodontic training in Germany and Switzerland. And when he began practicing, he focused primarily on treating adults using Invisalign and lingual orthodontics. He's actually treated over 1,300 lingual orthodontic cases, which is incredibly impressive. He now devotes much of his practice time to providing early interceptive orthodontic treatment to younger children, with a focus on whole health orthodontics. And during today's episode, we're going to talk much more about both what prompted him to make this switch and how it's going. Steffen has served as a member of the Global Advisory Board for 3M and as an Invisalign clinical speaker. And he's currently director of the Masters of Science in Orthodontics program at both the City of London Dental School and Bolton University. He's an ambassador for the Breathe Institute in Los Angeles and also a faculty member for the prestigious Kois Center in Seattle. So with that, I would like to welcome the world-renowned and very impressive Dr. Steffen Decker to the show. Welcome to the Doc Podcast, Steffen.
Thank you so much for having me. I think it's going to be lovely today. I can't wait to share our passion, to get out there the messages we should get out there. So it's going to be great.
I agree. I love your story. I love your passion. I love your enthusiasm for this topic. And we have so much in common where that's concerned. And I want to just kind of start by having you tell your story. It's something that inspired me when I heard it. I wanted to have you on. I wanted to talk about it. And I feel that way because I know there are so many listeners to this show that really do relate to what you went through and the journey that you've embarked upon. And maybe they just don't know that there's someone else doing this or has had this sort of transformational change in the way they approach orthodontics. So how did it all happen? Tell a little bit about how you started practicing and that evolution that I referenced in the opening of how you practice now.
I'm ready for this. So basically in 2008, I had the luxury that I was trained. First of all, in Germany, you can be trained in a private practice, and then you have to do one in hospital. So I started off with 2 years in a private practice, and my former boss, she was just incredible. She sent me on all of different courses about lingual, mini screws, and it gave me a lot of value because basically wanted me to run her business more or less self-sufficiently from the get-go because she got that I have a talent, that I can do this. So I didn't even realize at the time how good she was to me, giving me all the opportunities. But I really appreciate it now because also at the time, we treated predominantly children. In Germany, my education is children. Like I never ever had to write a treatment plan on adults ever in my specialty training. And with her, she had body workers and osteopaths and myofunction therapists coming into her clinic every time we did bite corrections, like if we used activators or something where we changed the bite, we had a body work osteopath coming in who checked the legs while we did this wax bite. And I always was wondering, hold on a minute, I've never heard about this. Then they explained to me that the legs are shifting and the body responds very differently to different situations. So that was the beginning. Then I went to the university for 1 year, and then I went to Switzerland. And basically, in Switzerland, it's all private. And I could do early interceptive orthodontic with the classic approaches. I was learning at university in Germany, which means Schwartz expanders and all of these Frenkel device, activator, binet, twinkle, the classic way of doing orthodontics. I did that for about 4 years. And in 2015, I moved to London. And in London, in central London, there are no kids. It's only adults. So at the time in Switzerland, I treated every kid that needed fixed faces with lingual. Why? Because the risk for demineralization is far less compared to buccal braces. And I was very early in my career that there's a massive need for cosmetic orthodontics. So at that time, for me, that was only lingual because the aligners weren't that popular at the time.
Mm-hmm.
But then I came to London, so I realized, there's no body worker, there's no speech therapist, there's no myofunctional therapist, and I treat all of these patients, but I can't connect them with all the other parties. So basically, I treated all adults with lingual braces, but that's it. I literally forgot about my passion, my fundamental training in Germany of how to treat children because I didn't have them.
Mm.
And I had maybe one or two kids in a year. And I was really happy to see these children. I said, wow, how come that you come to see me in St. London? And then about 4 years ago, I was approached by an upcoming kids clinic in London who had the concept of treating children with fear, because also in London there was no kids clinic.
Mm.
So I joined their clinic and I thought, okay, let me start orthodontics there. And then lockdown happened. And I had time to actually educate and look what's going on. I did all the course like everyone else. And I realized, a lot of people who are teaching with me in lingual world, they're doing aligners more and more. It seems to be quite powerful. And in the right hands, it does seem to work now.
Mm.
But I was very skeptical. But with more and more reading and listening to all the speakers, I thought, I think that could work. So I went back to the clinic and said, okay, I'm changing now. I will swap every case I treat with Schwartz expanders and these devices with aligners. And suddenly I realized, wow, these kids are loving it. These kids are wearing it all the time. We get amazing success. And I have grown the business dramatically. So I never ever did any clear aligners in my life. I started clear aligners on kids and I have grown a tremendous amount so that I became my first year being an Invisalign user, top 1% Invisalign user based on kids.
Mm.
So this was the time where then I realized, wow, why is nobody doing this? And why, why am I alone here? So I said to my wife, I want to do my own business because there's a massive gap in the market. And for some reason in UK, the health system caters only for children above 12 years of age. So
Mm.
in permanent dentition. But all my training was on kids and prevention and growth guidance and growth manipulation, all of these things. So where is this going? So we opened our clinic about 2.5 years ago, and I will never look back. So when we opened it, it was based on kids, marketing on kids, and we're growing really well on kids. And the more and more aligners you do, the more you understand the benefits of it. And then also in lockdown, I found more topics, not only speech therapy, myofunctional therapy. I knew that already for my German training, but I also realized, with this breathing, I think there's also a link there. There's a guy called Soroush Zahgi in LA. He talks about tongue ties and how
Zahgi,
this
yeah.
is
Mm-hmm.
linked. And I thought, that's really interesting. I listened to all this YouTube stuff he had online. I said, this is so interesting. It does make actually sense. And that's why I became very passionate about, wow, where is this going? Where's this link of arch expansion, tongue positioning, tongue tone, lip seal, nasal breathing? How that can make a massive difference to these kids. But not only that, at the same time, I was trained in Seattle with John Kois.
Mm-hmm.
And John Kois, his whole courses are about functional occlusion, destruction on adult dentition, and how to treat them efficiently and how to diagnose these bad bites. So I went to John and I said to him, what would happen if, as a kid, they would have had adequate treatment early on? Would we see that destruction and these traumatic bites? Would we see these changes in the dentition? And he said, possibly not. So this is where it became really interesting because
Mm.
suddenly I started seeing wear on permanent teeth very early on at 6, 7 years old already.
Mm-hmm. Mm-hmm.
And then I had kids coming, getting earlier and earlier to me at 4 years old with wear on the teeth. Then when you listen to Dr. Zahgi, he says, tongue tie can be very much linked to tooth grinding. And you start asking now these questions in your consultation to these patients, and you think, well, they're all telling me the same thing. Tongue tie, snoring, breathing, tiredness in the morning, concentration. Then you look a bit in the media, ADHD seems to shoot up through the roof. How can the bit suddenly be happening? Then you read more about the diet change, and you get just really deep in the topic, and then you try to figure out your own story, your own link, and then the whole story is then that I went back to my own kid. I have 3 kids. One of them are twins. So they're pretty similar. They're twins. So, but one, he had a habit. He sucked on a teddy bear every night, and his mouth was open every day. I have the pictures. I went back to all the pictures. And he had tonsil infections every 2 weeks with high fever reaction. So for a year, I had to go back in hospitals, spending days in hospital to find out what is wrong with my son. He has consistently fever, high fever, and they don't know why. So now I know that he was a mouth breather. His arches were completely narrow, and tonsil infections can cause obviously reaction. Since the adenoids and tonsils have been removed, he never been ill since. So when we speak to ENTs, Dr. Zahgi, the first point of call we have in young children is to remove the tonsil adenoids to improve airway. But we as orthodontists actually have a huge part in that to maybe look into the airway, check if there are adenoids and tonsils. We can check if there are narrow arches. So we actually could play a fundamental role in early detection of problems that can happen. And then, because I still go once a week into London seeing adults, I now see adults 30 years later. Like my wife said to me when I met her first, have you seen your cases 30 years later? And I see the teeth have been extracted. I see that they don't sleep properly. I see some of them have medication for depression. I see some of them drinking because they need to drink themselves to sleep. So that there are, of course, extreme cases. But I thought, wow, when did this actually start? And then it's when it becomes really emotional because you realize, hold on a minute, this is a quite common problem I see nearly every day. And then you start talking more and more about you, of course, be guided by the experts, which is for me, Dr. Zahgi in LA. I mean, he does an amazing job in research. So I really closely attached Derek Mahoney in Australia. So they're all people in the world who talk about this for a long time. And so my direction went basically from the kids training, very good training in Germany, to forgetting about it because the system wanted me to forget about it because I had nothing there, to finally getting back to my passion of children. Number one, because I can do now my own clinic, but number two, because I realized these kids need help. It's not good enough to tell children, which I hear every week, we can wait to secondary school, but we ignore that they're getting bullied. We ignore that they might not sleep properly. We ignore the health impact, the trauma risk they're having. We ignore their severe crowding, that they might need extractions. I'm not
Why do you
saying.
think? Why do you think we? Why I completely agree with you. Why do you think it is that we ignore that as orthodontists?
Well, I think, look, in the UK, the system is between 12 and 18. The system pays for treatment.
Okay.
So it's a free treatment for IO10 score of 4 or 5. For severe cases, it's a free treatment. That's one thing that people think, I want free treatment. In
Okay.
Switzerland, it's different. It's all private. So that's number one. But number two, the orthodontists, they have a contract with the health system and they get a certain amount of input of patients. They can treat the way they have been trained to treat them, with extraction, without extraction, and they're getting the money in their pockets at the end of the month. So there's not a huge need to question, is it good what we're doing? Can it be better what we do? Because they are in a comfort zone. And we know somebody in a comfort zone doesn't want to get out of the comfort zone
Sure, right.
because they're comfortable.
Yeah.
So, and when I went to UK, I had to reinvent myself again because I went from children to adults. So what do? Okay, I do lingual on adults. I became really good in it. And then I was approached by kids. I had to change back.
Yep.
So because the market is so competitive in London that you need to offer service that is different. I had to reinvent myself. I was
Mm-hmm.
forced to. So I was never in the position that I was comfortable.
Mm-hmm.
So I had to think about what can I do different? Why is something not working? Why is something working better? So it forced me to. And my belief is because in the UK, and more and more treatments are being done by general practitioners, dentists.
Okay. Yeah.
Because
Same in the US. Yeah.
the big companies, aligner companies, we don't want to mention names, they're approaching dentists and saying to them, you can do this.
Mm-hmm.
But some of them, they might do really well education and they're really good in it. I don't want to deny that, absolutely.
Mm-hmm.
But some of them, they they reach, they don't even know their limitation and they
Mm-hmm.
go over their limits. And then when it fails, they understand, oh, I don't know why it failed. They don't have the skill set to see why it's failing. But the problem for us orthodontists is that the market coverage, when the dentist undercuts your price, then the customer will decide by the price you're offering because they don't know anymore the difference. And that is why actually I called myself the orthodontic specialist because I want to point out I am the specialist. I'm not a dentist offering orthodontic services and veneers and fillings and everything else. I'm a specialist. I know about growth and development. If you want to see a specialist for your child, I'm the one.
Mm-hmm.
Because teens and adults is so competitive and the differentiation is not quality anymore. The differentiation is price.
Interesting.
And
Yeah.
in kids, it's because it's an emotional connection. In kids, the parents, their kids come home, they cry, they're emotional, they raise concerns, and then the parents say, "Okay, we go to a dentist." The dentist says, "No, let's wait, let's
Mm-hmm.
wait."
Mm-hmm.
They're
Mm-hmm.
waiting years and years until then, at the age of 12, 13, they might be telling them, "Now we need to extract 4 teeth."
Mm-hmm.
So the parents feel in their gut, hold on a minute, that just doesn't sound right. I was asking for help for years, and now you're telling me I'm taking 4 teeth out versus Dr. Decker says to me it doesn't need to be that way if we
Mm-hmm.
catch it early. So they understand more and more that there's a different way. And of course, with the social media we have nowadays, we can educate. We
Yeah.
can educate parents, we can educate patients, we can educate our colleagues
Mm-hmm.
that there's a link and there's a need for this. Yes, not every kid needs early intervention, absolutely.
Agreed.
But for example, I had a child, he had a gap in his front teeth, and he was called a slot machine.
Mm.
So that bothered him so much that his only wish was, can you please close the gap?
Mm-hmm.
That is it. And from an orthodontic point of view, if I would say now, sorry, I can't help you, get
Mm-hmm.
continue being bullied for another 3 years' time, I don't care how it affects your mental health, is not the right approach. Yes, from an indication point of view, it's not IO10 or 4 or 5. There's no necessity for treatment, but there is a necessity because the kid is suffering and the kid himself raises concern. So I think it's wrong to then say as a clinician, sorry, mate, we can't help you, wait. So it's a fine balance to say, okay, I'm also a person when I do diagnosis, say there's no need. I
Mm.
don't need to do
Sure.
this.
Yeah.
But if it's needed, like there's certain things where I clearly say, look, you're growing in the wrong direction, you have a crossbite, you have a habit, whatever it is, it's absolutely indicated. I think it's really important that we don't get the reputation of treating every child because
Agreed.
we want to make money.
Yep.
No, it's not that way. We want to help children and listen to children. And if they have a need, it could be protrusion, could be a gap, whatever it is, at least acknowledge that there's a wish, a concern, because we don't want to rush them and feel them not listened or heard. So I think that's really important to understand. And yeah, so that's where I'm at the moment. And I see my patients getting younger, younger,
Mm.
younger.
Mm-hmm.
That actually now my wife and me, we are saying, oh, I think we should maybe do some marketing for teenagers as well, because actually orthodontics, classic orthodontics is teenagers. But we're having such good education on the prevention side of things that that's why people come and see us now.
Mm-hmm.
And the airway is a complete new topic. I mean,
Yeah,
when
talk to
we
me a little bit about how you did you stumble upon that? Were you just kind of noticing? I know you have your own personal story with your son you reference, but how did you start to put together the concept that wait a minute, I'm getting in on these kids younger, but there's a connection to the airway?
I think when you listen to Zahgi,
Mm-hmm.
um, you see, okay, there. I mean, I would never have said I look at tonsils, at conchae or in ears or anything like this, because I'm not an ENT. But when he talks about the link, and Christian Gimino in LA, Stanford University did
Mm-hmm.
everything before him,
Mm-hmm.
you start then asking these questions to parents. And when you see a narrow arch, it's only one question to ask: how's your child sleeping?
Mm-hmm.
That is it. You can check a tongue, you can ask questions. And then when you realize that a lot of moms struggle breastfeeding their children, a lot of moms complaining that their kids is very hyper, they can't concentrate very well. You see it already in the chair, they are all over the
Oh
place.
yeah.
Yeah.
Yep.
Then you start seeing that look, there's something about this.
Mm-hmm.
And then even sometimes you have these parents who sit a bit on the fence because it's so new. They're coming to an orthodontist because they believe we move teeth. And
Right.
then one of the first questions I ask, how's your child is sleeping?
Yeah,
They don't
same, same.
they,
Yeah.
they don't expect that.
Yeah.
And they're
Yep.
a bit like, hold on a minute. Are you telling me now my son is not sleeping and my son is dead? And they're denying,
Or
first of all,
they'll say,
everything.
what does his teeth have to do with how he sleeps? Like you'll hear that one a lot. Yeah.
Exactly. So then you see, okay, they're a bit apprehensive to that, but then you ask more questions, and
Mm-hmm.
suddenly you see in the head,
Yes.
hold on a minute, he's telling me the life of my child the last few years, and
Yep.
he's never met my child.
Yes. Yeah.
The,
It turns into how
and,
did you know that? It goes from why are you asking that to wait, how did you know that? Yeah.
and that is then when you get them and the emotions coming, especially
Yes.
from the moms,
Yes.
and then they say, whoa, what is happening here?
Yes.
And then it's quite funny actually, because quite often they go home emotional
Yes.
because I said them the story of their child, and they're going to the dad, the husband. I said, we need to do this. And the dad, the finance minister, says, hold on a minute, but that's gonna cost me money now.
Yep.
I don't know. It's only teeth and all the things.
Yep.
But then actually, when you have a Zoom call with them,
Yep.
and you explain to them, and don't forget that's the princess or the prince sitting there from the dad. He
Right.
has a heart as well in emotions. He says, I understand. That makes complete sense to me.
Yep.
And I have even a dad who said to me, when I show him all these AI simulations and everything, he said, I felt like it was a sales pitch, and he's showing me these amazing pictures, how it can look at the end. But if it comes close to what you're promising me, I will be really happy.
Mm-hmm.
And then he said to me, but everything you said was true, and you did exactly what you said.
Yeah.
And that is when it's like a wildfire, it's like a snowball.
Yeah.
You don't need to do any marketing because
No,
they
I
talk,
agree. I say that all the time. I agree. Yeah, your
they
marketing
talk.
becomes your brand. People seek you for this because especially because I guess, at least in the US and where I was in upstate New York, you're an outlier. I was the only one looking at airway, understanding this, working with my ENT and allergy colleagues, talking to the parents about this. And then that parent goes and says, well, first they say, oh my gosh, I have a 5-year-old or a 4-year-old who I think is on the same track. And then they go and they tell their friends, and then their friend calls and says, oh, so-and-so came and said, oh my gosh, you'll never believe this. We went to Dr. DeLuke and he actually realized and was the first one to ask questions about how Johnny was sleeping or breathing or, understood that it was maybe tied to his hyperactivity. And he sent us to this ENT or whatever. They tell that story. And so I say that all the time. You don't have to market it. I never marketed as like someone who did like all this, early treatment or was treating and looking at patients' airways. Never marketed it. But patients would call and seek it because as you said, it's emotional. You're tapping into something that no one has ever done. And I want to touch on that because that is, I think, one of the biggest differentiators. People who are so passionate about this, as you and I are, and as a lot of people I speak with and have had on this show are, they do something, and you said it. You referenced listening to the patients, and you also referenced taking the time to diagnose. And I think those two things are things that are really profound. And the third one I'll add to that is lack of training. So if you take somebody who hasn't been trained in this stuff, right? I don't even necessarily mean airway, just hasn't been trained in even treating or looking at 6 or 7 or 8-year-olds from a breathing perspective, or people don't realize this, but a lot of orthodontists out there in the US don't have a lot of training and even treating a 6, 7, or 8-year-old period, like ever at all. They just don't get to see them a lot in their training. So you have that one obstacle. Then you add in, they get busy. It's really easy when you're a busy practitioner and you're straightening teeth and you're, as you said, comfortable in that, to just kind of keep doing that and not look deeper into the why behind things. And then if you didn't learn it, you don't listen to it. Now you can not take the time to dig in and diagnose the actual etiology. So you hit on all three of those things. And I want to recognize that to say, I really agree that all of those things are so important to take the training, take the time, and then to do the diagnostic work and really have the knowledge to look into this more. So how do we, you and I, kind of the people who are on this journey and really are passionate about this, how do we get that message out outside of just talking about it, which is super important, which is why I really have this show and why I do what I do to bring that awareness? How do we get our colleagues to, because I do feel that in the US, at least, general dental and pediatric dental colleagues, they tend to get this a little bit more easily and they are a little less opposed to a lot of this. The orthodontists are really dug in that there's no place for this. A lot of them, not all, and it's getting better. And the younger docs coming up, especially the residents I teach, they're so interested in this and it's getting there. But there's still a big majority that are opposed to this. Even some of our leading governing organizations feel that way. So how do we overcome that? Hey, everybody, be sure to check out the Doc website where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode.
Very good question, because I asked myself the question, like, the thing is for me is, it's nice if you help your children in your community. And when you do this, you realize that it's not only your community you're helping, because suddenly people travel hours, sometimes taking flights to you to get this opinion. So the radius is suddenly massive. So when you wrote your initial business plan for the practice, it was a 5-mile radius, 20,000 children.
Right.
Yeah, but now I have patients from Norway flying in, Hong Kong flying in, Sweden flying in, Portugal flying in. They're coming to me. I said, hold on a minute. There's something not right here. Because why you're flying in? So I think I realized my radius is not big enough. I need to teach. I need to teach dentists, orthodontists, whoever is interested in this, because they are going back in their community and they can do that. But it doesn't stop there. What I do in the academy, we have an academy with teaching courses. I offered my students a mentorship, meaning to tell them from the beginning, when you start with this, you are not alone, because I understand it's so new. You're scared. It's kids. It's emotional. You need someone who is experienced to hold your hands, at least for a certain amount of time, depending on your experience level, to get them confidence. And I do this. And the beautiful thing, what I see now with my students is that when I mentor them, they're getting more and more confident. They're speaking more and more your language. They're seeing more of the things, which fills you with absolute pride, because you said they get it now.
I'm so glad you said that, because I have with my residents, they'll come to me with a certain case, or they'll be like, I saw this patient last week on a day you weren't here. And I hearing what you've been talking about, I started asking airway questions. I'm like, Yes, that's it. That's it. Even if they don't necessarily understand the plan yet or how to approach it, they're just starting to think differently. So I completely agree on that. Sorry, I wanted to throw that in. Go
And
ahead.
the thing is that then you might think, okay, why is he sharing his knowledge? They might be their competitors or whatever. It's nonsense.
Right.
There's such a huge amount of help needed
Yes.
that we all need to do this together. So my students always say to me how grateful they are for the everything I share, my failures, my successes, every single detail they get from me, because I'm only that way. It's
Mhm.
100% or nothing. And they really value that because we need to give our hearts out because it's about children. So I would think to answer your question, we need to educate, we need to teach,
Mhm.
we need to create awareness via our channels, social media, and all the other channels, because we need to give them a kind of guideline, like questionnaires, for example, is your child mouth breathing? Is your child doing that? Where parents easily can say, hold on a minute, I have yes answers to nearly every single question he asks.
Mhm.
There might be something going on and he talks about it. I want to get an opinion. And hopefully, at one point, we make it that far that in every community is one who has been trained that way,
Yes.
who can help these children because together we are strong. As an individual person, we have completely isolated, we will not do anything. So, teaching is a massive contribution. And actually, next year, I will be teaching on Kois in Seattle. So, about this. So,
That's
I'm
great.
trying to get there because it's such a need.
Mm. Yeah, that's actually an interesting story with John Kois. I never met him. I spoke with his son a couple of years ago,
John,
who works with him as well. But his niece, it would be Chelsea. It turns out she was the genetic counselor on the cleft craniofacial team I was on in upstate New York. And I just Chelsea Coyce recognized the name, didn't even think there would be a connection. And then one time she said something to me about, oh, do you know have you heard of my uncle and John Coyce? And I'm like, wait a minute, what? Like that. And so we got talking about it. So she put me in touch with her cousin, his son, and John's son, and we had a great talk. I was telling him a little bit what I'm doing, but you've inspired me. I'm going to reach back out and kind of because that was just when I was kind of breaking away more from the clinical side and into the teaching academic side for the reasons you just alluded to, because I really did feel that I can do more teaching this than I can do just alone with my own two hands and my own community, as great as that is. As you alluded to, said perfectly, your outreach is limited, but I'm reached back out because I think that collaboration, all of us just working together, is just so important.
100%. We have, and also the interesting thing is like John does every year a symposium for all his credits. So once a year, the top dentists literally from the world coming to see John, what's new on the scientific side of things, new evidence, new research. And if you look at the last symposiums, more and more research is coming out on airway and
Yeah,
expansion.
yeah,
And he talks about it. So an evidence-based education center like John Coyce is talking about it. So
yeah.
it can't be that wrong.
Right, right. Instead of it just being isolated where people who follow John or are aware of John know it. Now you talk about it, I talk about it. We all start to bring, and then other people raise awareness, because I still feel like the loudest voices in the room still are the ones who oppose this. They really oppose this. I mean, I had a little interaction on social media with someone this week, which won't go into the details of, but the point is he labeled what I'm doing as fringe and niche, and kind of trying to do this for self promotion purposes. And he doesn't know anything about me, who I am, what I am. He's just clearly opposed to my philosophy, which a lot of, I understand, my colleagues are, and I get that. The thing is they're not willing to learn. No one and I challenge every one of them. I challenged him openly in this social media interaction. I said, it was a specific case we were talking about. I said, message me. And because he didn't understand what I was saying, I said, I'm happy to go through this in great detail with you. I will talk to you about everything I'm saying. And then he came back with a remark. And I said, fine, if you don't agree, then let's have a public debate on this, which I have challenged multiple people who don't agree. I said, let's just have a public debate. We'll have someone from this forum host it. You and I can just go back and forth on how we approach things like this. And his comment was, he would basically not going to stoop to my level because he's an orthodontist and he does orthodontics and I don't. And so it's like the arrogance of that is just, I mean, I actually said to him, it's so funny, Steffen, because I said to him, like, I actually feel sorry for you. I literally said that. I said, I really do. I said, I feel sorry for you that you are this close-minded and arrogant about this and dogmatic, that you're so unwilling to see any other way to help these kids outside of straightening their teeth. And that is all you care about. And I love straight teeth. It's, I've done it a lot. I've made a lot of very beautiful smiles throughout my career, and I'm very proud of that. Nothing compares to when you change the life of a little kid and their family through helping recognize growth and development issues, especially related to airway, redirect that. And as you said, especially there's some aesthetic benefits that I didn't even anticipate that I had in some of these kids' lives, where they come to you afterwards and, the parent says, I didn't know this, but Johnny came to me and said, he didn't like going to school before he got braces because he was being bullied, or kids made fun of him, or called him, the one I heard for the space between the teeth, that you said slot machine. We heard SpongeBob. That was what we heard a lot for kids. So breaks your heart. And so all of these things, I really do feel bad for our colleagues who are so close-minded that they won't see this a different way.
What I do now when I teach is, the first question is I give them a bunch of questionnaires because I want to see who are my students. So I test, are they left brained or right brained? Because the left brain is the scientific, they want evidence. The right brainies want emotion. The people you talk about are left brainies. They want scientific evidence. The problem is that when you also speak to Zahgi, the evidence that is coming is case reports, and case report after case report after case report. And that is not classified as high level of evidence. But fact is, control groups is very hard to get.
Yes.
So there will never be high level of evidence. So there's always a bit of right brain in this.
Yes.
And Zahgi told me as a story of this airway. And I want to share this because it got me really emotional, because I understood who is Dr. Soroush Zahgi. So Christian Guilleminault discovered sleep apnea in 1971, something like that. So then CPAP was approved based on 5 trials, 5 patients. And why? Because money could be made at that point. But when they published an article of 350 children where they expanded the arches and improved the airway, they didn't accept that as high level of evidence. So the problem we're having is we will never get this evidence the scientific people want. So if you speak to these people, you need to know it, how to approach them, and say, okay, you want evidence? I give you the research that we currently have. But if you will have, and what I see, my students are all right-brained.
Interesting.
So the people who come to my course, I did the test. Honestly, they are all mostly right-brained.
Wow. Isn't that interesting?
Some of them 80% right-brained.
Wow.
So they are emotional. And most of them are female, of course.
Yeah.
But so if you ask your residents who you feel they get it, do this test of left and right brain, you will see they are right brained. And so when you speak to a professor who's completely left brained, and don't forget, Zahgi is a kind of researcher. He's more into. He said it himself. He had to learn to get connected neuroplasticity to get his right brain bit connected, because kids is emotional. And when you become a father yourself, your connections change as well. And if your child is one of them with these symptoms where you heavily denied for years and years, like it was in my case, oh no, there's no link, then you at one point you will question yourself, hold on a minute. I was always opposed to it and there's not enough evidence, but my child, my princess is going through that. I want to help her. So we need to allow people to be left brain, and it's the way it is. It's like you said, you felt sorry for him. I do feel sorry, because I think we all need a bit of right brain. We need emotions, because the high level evidence we will never get. It's not possible. So that is something which I would say to everyone. First of all, know your audience, who you're talking to. Is it left or right? That you can adjust your content accordingly. And when I talk now, I say, look, this is nothing for you now. You don't understand that the mom is crying. You don't
Yeah.
care about that.
Yeah.
You don't care about the kid being bullied. I understand it, but for the people who are right brained, you will get me. And they go like, oh, I want to help them. So it's really fascinating, but it's literally this problem of left and right.
Yeah, it's
That's
a
it.
really interesting point, and I completely agree that certain people are just more in tune to it than others, and for that reason, it makes complete and total sense. And what the thing about research too that's so funny is I can go. I mean, I will go in depth on research and go through the chronology of mouth breathing being known all the way back to Engel in 1907 and his statement on that. And I've gone through it many times on this show and other interviews I've done. And you can track where we've known this connection for a long time. There are a lot of good studies out there that talk about the development of the arches. Ricketts knew this in the 70s. He did a lot of studies on even airway and relationship to adenoid and tonsillar hypertrophy. And we know there's a lot of times that removal of adenoids and tonsils doesn't work in a high percentage of patients. That's all in the otolaryngological literature. And why does it in one and not the other? And again, we can go on and on in that. But the thing is the research, my point in saying that is the research isn't conclusive that it doesn't work either. So that door swings both ways. I agree. It's hard to get the research that could be double blinded. I've had people on this show, Bill Harrell. We talked a lot about, he's really brilliant in the research arena and why we can't get those studies and why there's some ethical concerns and obviously time concerns. You'd have to do these over. And the left brain people that are opposed to this, they know that. They know we're kind of in a corner when it comes to that. They know it. They're smart and they get that. I challenge them a lot of times too and say, show me the research that it doesn't work. Show me a patient that you started with at a similar point to my patient, right? And that you did do anything with them and that they had as great of an outcome as my patient. No one, honestly, Steffen, no one takes me up on it. I have offered to so many people to publicly debate me on this, have this open conversation. Let's show cases. Someone maybe 6-9 months ago, we had a kind of a debate on social media and talking about, there's no need to treat this patient. Was critical of my approach. And I said, I can take 10 cases easily right now and go grab them. No problem. I've got spreadsheets of all of this and show you how I took this approach and how it changed this patient's life. Pre and post cone beams, everything. I said, I want you to show me a patient that started at the same point at like 6, 7, 8 years old and that you did nothing with and where they were in 3, 4 years. Like say I did a year of phase 1 and then retention. I said, you show me where they were as an adolescent. Okay. And we're going to compare whether or not I actually did anything, right? Because right there's just a small sample size study essentially. And no one takes me up on it. No one does because like you said, they're afraid to almost see something that changes so hard. And when I went through this change in my practice, and I'd like to hear if you felt the same way in yours, I didn't start doing this. This wasn't something I was trained in. It wasn't like I started my own practice right out of residency, ran it my entire career, never had anybody work on any of my patients other than me or my clinicians that I trained, but no other orthodontist. So I did this all myself with my own 2 hands, and I had to figure a lot of this out as I went. And when I made these changes, even just implementing a cone beam into my practice was like really hard to do, change all my processes and protocols and systems for diagnostics. And I just think a lot of people, they just don't want to do it. They can put their head on the pillow at night that they're straightening teeth, they're doing a good service for the patients. And also, they don't have to do what you challenged yourself to do and your wife challenged you to do and you then did, which is what are these patients like 25, 30 years down the road?
I just want to say, you talked about the comparison in a teenager, but I would like to see the case we maybe change some functional things very early in life, the tongue position, the breathing, very early, how they look 30 years later compared to a perfect class 1 case with a tongue tie, low tongue posture, and mouth breathing 30 years
Right.
later.
And narrow
Because
arches and high vaulted palate, all of the, exactly. That's
so,
such a great point, Steffen. Let's look at those 2 cases and see the breakdown, the stability, the functional aspects, and not just with their mouth, their overall systemic health.
yeah, because like I have an example where I had a child. She was a big habit. She had her finger in her mouth until she was 8, 9 years old. The mom tried everything, painting the thumb, everything. So I said, okay, I have to be very cruel. I put her spikes into her mouth.
Mm-hmm.
People will condemn me for that really nasty device. But the child never put her finger in her mouth ever again. 3 years later, I've never seen this patient ever again. The bite was closed from 1/2 centimeter open bite
Mm-hmm.
to complete closure of the bite with hardly anything to do. So that's just one example. So when we have a massive tongue tie, we are thrusting. If we just correct this little tongue tie or mid-tongue restriction, whatever we want to call it, that could, and change the swallowing pattern, that could mean that eventually they don't require anything later because the
Mm-hmm.
teeth are great. So, because what my wife said to me is these perfect class one cases actually don't matter unless you treat the function around it, who gives you the stability of the perfect class one.
Mm-hmm.
And when you look at a lot of congresses, you in the liner world, you see these sequential digitalization cases of adults
Mm-hmm.
where they basically move a skeletal class 2 case into a dental class 1.
Yes.
And when you speak to John Kois, he goes like this, says,
Yeah.
what you doing? Because they're completely constricting the envelope of function. And the airway, the jaw has no space to go forward because when you look at the sleeping devices, sleep
Yeah.
apnea, they're all moving the jaw forward. If you retract everything,
Yep.
that's going to not be good for these patients. So
that was actually interestingly, Steffen, that was the type of case that I referenced that I was debating this gentleman on, was that exact type of case. And I was talking about the etiology, needing to determine the etiology. And it wasn't as much retrognathia as it was, there's a severe overjet and was protrusion of the upper incisors, retrusion of the lower, so there's a lip habit. I go into all this, and his question was, what's the etiology? You didn't say what the etiology was. And I'm like, well, I actually did. And his point, so that was why I offered to talk to him about it. His point was the etiology is genetics. He literally said there's a mom and there's a dad, and that is how malocclusion is determined. And at that point, I literally was like, that's why I offered to talk to him personally. Because I'm like, I'm not going to go back and forth in a forum online. And I mean, it's just, that's so fundamentally wrong. And we have so many examples of that. I mean, even if you just look at Corcini's studies and you talk about the anthropology side, you talk about Harvold in his studies in the 70s and 80s. I mean, there's study after study after study of the, in Melvin Moss, the functional matrix, right? I mean, this is the fun foundation of growth and development. And that patient you just explained with the anterior open bite. So is her etiology of her open bite genetics? No, of course not. There's an environmental influence. So I don't, and I, by all means, I think he's a very intelligent guy. I don't know, but he seems quite intelligent. And why are we fighting over this as colleagues? I mean, shouldn't we all want to do better? Do you have questions about a clinical case, or maybe a challenging practice management issue? Or maybe you're a new doc who's starting a practice and doesn't know where to turn for advice. Doc's private one-on-one coaching platform is here to help you succeed in all these areas and more. Just go to theorthocoach.com and select coaching from the menu to enroll. And now back to today's podcast.
What I just don't like about this, what you're just saying, is that they don't have the ability to listen to our opinion. I mean, we respect their opinion, we understand what they're doing, but I think it's really important for us as an orthodontist to listen to different opinions and to at least think about it and critically think about it. And when it comes to environmental influences, I mean, it's just a case, it's just a small low-level evidence, I agree, but I treat identical twins. Mm-hmm. One has a perfect class 1 and one has a skeletal class 3. Mm-hmm. The difference was one had a massive tongue tie and the other one didn't. Mm. So why did the tongue tie suddenly have a massively overdeveloped lower jaw or retrognathic upper jaw? Mm. Because the tongue has never seen the palate ever in their life. Mm-hmm. So, but that's only a case. I understand this. But the speech, I mean, how they speak with the nasal speaking, they're identical. So I think we should never ever say you're wrong, you're right. But I think the ability we have as humans is to think about different opinions and to critically ask, okay, can we do something better maybe, or maybe not? But I think it's wrong to say that my way is the only way. I don't say that about my things. I'm very open to discussions about everything, but for me, it needs to make sense. And if you go to all this holistic we're talking about, to me, it all makes sense. Mm-hmm. Why is one linked to the other? That we cannot just look at the nose or the ears or the throat or the teeth. we need to actually think, who is that human being behind that?
Yes.
You know?
Yes. Not to dwell on just looking at the teeth, but if you look at a lot of the literature that opposed phase one, and a lot of it, Gianelli had a bunch of stuff out there in the 90s and early 2000s, Tunke and Schiffman, Little, Rydell and Stein had an article in 1990. If you look at them, like Little, Rydell and Stein's, people talk about that Little with the little incisor irregularity index and all of that. I mean, they had this article. They were respected people. They put an article out in the AJODO in 1990 talking about their conclusion that phase one is not stable and in the end makes absolutely no difference. And then Gianelli kind of ran with that and was putting out editorials that was just basically to make money. And Tunke came out and said that anybody who does phase one and believes in it is a quack. I mean, these are pretty significant people within our profession and thought leaders. And so, but the thing is when you look at what they actually did, it was interesting. Actually, I encourage everybody, maybe put a link in the show, but a gentleman named Papadopoulos put out reviewed Tunke and Schiffman's article from 2000. He put it out in 2010, and he pointed out numerous flaws in their study. And the article by Little, Rydell, and Stein had numerous flaws. I mean, it was very few patients, 28 patients. I mean, Steffen, they didn't standardize the treatment approach or the retention approach across these 28 patients they looked at. And then their conclusion was phase one makes no difference. Well, you could say braces make no difference or Invisalign makes no difference if you don't have a standardized approach to it.
Mike, first of all, what I would say to this is, why did these different malocclusions develop in the first place?
Great point.
What's the reason for it?
Yep.
Tongue? Is it breathing? What is it? It's because if you figure that one out, you ask the why, and you can treat the why.
Thank you.
There will never be a relapse. I promise you.
Thank you.
Because when you cannot say,
and it's not just genetics.
If you have a crossbite correction, for example, you correct the crossbite. Yes, we all know we need to slightly overexpand because we get relapse. But if we get good suction hold, we get the tongue up in the palatal suction, there will not be any chance that this palate will relapse because the tongue will not allow it. So unless you consider the other parties, which is myofunctional therapy, into this treatment, I agree with the study. 100% you have relapse. It's all nonsense. 100%.
Right.
But this is the fundamental difference is every kid I will ask why. And if I know the why, I will try to treat the why, which means I need other people in my boat to row together with me. And I tell the patient, this is not a nice to have, this is a must. Because if you want stability of my result, you have to do this. Classic example, open bite, 35% relapse. But why? If you have a tongue thrust, you can do whatever you want. This bite will relapse.
Yep. Completely. It's the impact of all of those. I love that you focused on that of the treating and the etiology, because that's my big thing. And that's why in these studies, they don't talk at all about how these patients presented. They don't even talk about standardized protocols of treatment. It's literally, they take a handful of patients, they look at how they started, how they finished, and if it worked. And I'm like, and then we use those as the standard bearers to say that there's no value in early treatment. Yet anybody who does exactly what you just said, and what I say so often on this show and when I teach and lecture, who takes the time to diagnose the actual etiology, gets a comprehensive history of their patient and starts to figure out why this is going on, and then provides straightforward treatment at a younger age to address it. It's literally like this. It just happened. It's easy at that point. And the stability, I retain these. I had Tom Pitts on last week, and he's been doing this in a lot of ways for many, many years, well before many of us even thought of this, or we were even around. And he said, I didn't ask him. I didn't know how he retained his phase one. I retained mine with just clear retainers and Essex. And so I said to him, like, he was talking about how stable it is and how much it makes phase two if you need it easier and all that. And I'm like, Tom, how do you retain it? He's like, clear plastic retainers. We just cut the teeth out as they come in, which is exactly what I do. And I'm like, oh my gosh, you would think there's no way you could retain it that easily. But as you said, when you get everything in place and you've treated the etiology and the tongue has room and the arches are leveled and upright and broad, and you have all of you don't have lip pressure causing, the incisors to be pushed in different directions. It's equilibrium. Of course it's stable. We know this. This isn't new.
But Mike, I mean, I have to be fair. Like when I see go a lot of congresses and I'm a speaker, sometimes there are big people on stage and presenting these massive open bite cases and how beautiful they can close open bite cases with mini screws and aligners.
Mm-hmm.
But in every picture they show, they have the tongue like this.
Yeah,
And
sticking out. Yep.
not a word is being mentioned about tongue. So all these
Yeah.
new graduates from university, they come to these congresses because the big speakers are on stage. They think, okay, for every case we do mini screws, we do aligners, we intrude the back teeth, it will be all perfect.
Yeah.
No, there's a tongue, there's auto rotation of the mandible. They will eventually fail. But nobody has the guts to say, look, this is much more complex than it shows here. This is what we're doing. If you want to learn more, please come to my course before you try this. So it's about showing before and after without a clear, basically difficulty of the case and assessing the diagnostics. So it's a big problem that there's no quality control when we go to congresses where it says, okay, this is our etiology. This is what we want people to take away from this. It's just before, after, without actually telling them why and how it's going to be done. So I see that a massive problem. That I feel sorry for the youngsters who learn orthodontics that they think, okay, it's easy as that. Put some aligners in, put some meniscus in, done, no problem. Because it's not as easy as that. And we need to also all the studies, like Steve Lemberg, who's a big airway guy in the US. He also says about all the studies are monotherapy studies. They look at one aspect of the treatment. They don't consider the whole circle of dysfunction, like
Yeah.
Zahgi calls it.
Yeah.
They just pinpoint one dimension of this, and then they make a conclusion and they shoot it out in the world, and then people think it's not working.
Yeah, and oftentimes that one parameter is OSA, is obstructive sleep apnea. And when you're talking about that in kids, the validity of an obstructive sleep apnea, and just briefly, I think a lot of people who follow me have heard me say this, but just for those who maybe haven't, obstructive sleep apnea for children, there are no data and no studies that were conducted to determine what those ranges should be. They literally just took the adult ranges, made it a third, and made that the parameters. And so you look at these numbers that were essentially constructed, and then we make that the holy grail of whether or not a patient had any change with our treatment, when you're actually, your scale that you're using to measure is completely off and unreliable. And the reason for that, just a little more complicated, but the quick explanation is kids' sympathetic nervous systems are much more alert. They're much more active. So for having a true apnea or hypopnea to register on the AHI index, the apnea hypopnea index, which is what you use for an OSA diagnosis, it has to be an episode that occurs for cessation for greater than 10 seconds. Well, a lot of these kiddos, they don't have, their sympathetic nervous system won't let them have that. It activates the brain and stimulates them to move or turn or toss or turn. So there's all these other things you need to look at in these kids to determine if they're having sleep disordered breathing and related issues. And they might register as having a 0 on the apnea hypopnea index. Yet you'll look exactly what you just said, Steffen. You take a study and all they talk about is that one parameter of whether or not it changed their diagnosis of OSA. And nope, it took their average OSA from 1.2 to 1.1. So it's an insignificant change. So this doesn't work. And it's like, oh my goodness, I don't even know where to start by explaining how flawed that is. But what you said, it so perfectly, is then they take that and they run with it and they say, oh, there's no benefit to a pediatric airway for these different treatment modalities.
Look at this story of Christian Gimeno. He went to his Italian friend, the heart surgeon, he realized my patients that are snoring have a high heart rate. Christian Gimeno said, oh, let's look at them. Oh, I think they stopped breathing as well. Sleep apnea was discovered. Then they said, let's put a tracheotomy in them patients. Oh, they sleep brilliantly. Let's cut their throat open. They sleep brilliantly.
Mm-hmm.
That guy decided, oh, I don't want that. Let's try on a French bulldog to try a reverse Hoover. Oh, CPAP was discovered. Perfect. Then they realized, oh, I think it's adenoid tonsils. Let's remove the adenoids and tonsils.
Mm-hmm.
Then they realized, oh, it could be craniofacial development. Then they started expanding. Then it got into tongue. This story is not finished yet.
Yes.
We don't actually know yet how complex this whole story is,
Yes.
how much is diet, allergies. So, we have to look in a much bigger picture. We need to be open that we understand much more research is needed. So I really appreciate people like Soroush Zahgi, who's in the forefront of research, because this is the beginning of the story. And what you talked about with kids, I ask every parent where I suspect sleeping disorder in a child to have a baby monitor the whole night on the child and send me the recording.
Mm.
How often do they move?
That's neat. Yeah.
How do they overstretch their neck? How is their chest moving? Because these are all things you can see in a child that they're not sleeping really well. There's an issue going on.
Right.
Independent from what this test is showing them.
Right. And no matter what, whether they have greater than 10 seconds of an apnea or hypopnea. Right.
Just look at your child, what it's doing all night. And how are they waking up in the morning?
Yeah.
I mean, it's just,
Steffen, that's the left brain, right brain, right there. What you just
absolutely.
said, the left brain people, right? The left brain people are like, no, I need AHI greater, 1 or greater to do anything. And the right brain people are going, but my goodness, this child is suffering. Like this is, I can't leave this kid doing this. And I do think, and I said this with Stacey Ochoa a while back on one of our conversations that we had on the show was, I do feel you touched on this, that women are more sensitive to this. Maybe it's the maternal instinct. And some of us guys are coming around, people like us and as being parents and fathers, and maybe we're more sensitive to it. But even the young docs I train, the residents, I feel a lot of the younger male docs are starting to really get this and have that empathy and sympathy for these kids. But I find that for the females, it's almost a visceral reaction. When you show them pictures of a child that's suffering, a video like you just said, or when you show them a before and after of a kid, and then I play the video of mom or dad talking about what this kid's life was like. I have an episode I did, my goodness, about 9 months ago now on the show with parents of a 6-year-old patient I treated and had major airway issues. It's a really cool story. Dad was a certified registered nurse anesthetist. He was literally, Steffen, getting up with his daughter in the middle of the night and holding her head up, doing a CPR chin tilt to let this girl breathe at night, because he knew from his profession the damage that was occurring by this girl breathing like this. And when you hear their story, if this doesn't motivate you, and I love, again, what you said about the left brain, right brain, because I would say, have this conversation or say this to people, and now realizing those are left brain people who are just like, yeah, but there's still no evidence that, doing anything to this kid this young actually did anything. I'm like, how about mom saying that 3 months after we started, the kid stopped snoring and she had a different human on her hands? Isn't that enough to at least try? I mean, we're not talking about anything too invasive here.
That's the point where I would ask this person, do you have children?
Right.
What would you feel if your own child is going through these things? I mean, every man has emotions. I believe that, much less afraid as we are when it comes to your own children. Oh my goodness, I had my children nearly dying in my arm with meningitis. It gets to you.
Yeah.
I mean, when your child is born, you hear the first scream of your child. It gets to you. You're human. So I would always say to him, forget your left brain for 1 second and think about, you are dad of your son or your daughter. How would you feel if your daughter or your son is going through these things? And if someone is saying to you, we might not completely cure everything because it's so multifactorial.
Correct.
But we might be able to help you in a certain way. And that we are very clear on that. We are not saying we're curing everyone. But what we're saying is, with the whole team approach, we can help children in different ways to go maybe healthier, better forward and help them. This is the whole thing. But it's so complex, and I'm really honest with you, I still struggle, because when there's a price attached to all of these parties that need to be involved in it, it becomes a huge price tag at the end of it. Because if there's an ENT in it, a speech therapist,
an allergist, a myofunctional therapist, right.
And the parents need to invest that money for their child to get to the bottom of it. Some of them actually just can't afford it.
Yes.
As hard as it is, what we are talking about is something for people who can afford this.
Yeah.
And this is where I get emotional again, because how can it be that way that only people who can afford have access to this kind of diagnostic to eventually get to the bottom of the problem?
Mm-hmm.
I think this is another big point where we need to talk about that insurances as well need to pick up the game and say, okay, we recognize this, we need to support families in that, because on the long term, we save a lot of money in helping these
Yes.
children early
Yeah.
because they will not have all these traumas later.
Yeah, it's the proactive approach. I've said on the show before, Peter Attia in his book Outlive, he talks about medicine 2.0, which is kind of what we're in now, the give it a drug, a pill, a surgery, and 3.0, which is, well, let's figure out why this is going on and stop it from getting there. And the other, a couple things you said, which I really love. One, yes, I 110% agree that we are not ever saying that we are treating sleep apnea. I never told those parents in the beginning with their daughter that had these snoring problems that I was going to solve it. It's a long story, and it's a great story that we go through on having them on the podcast. But the point is, again, I detected certain issues, was able to work with the appropriate medical professionals, and then normalize the transverse deficiency that this girl had at a young age. And all of those things combined changed this girl's life. And so when we're able to go back to what we started talking about at the beginning of this episode and take the time to look at the patient, diagnose the patient. If I had never asked mom came in because the girl had one little protrusive front tooth at 6 years, 10 months, 6 years, 11 months. I had to ask the questions that you alluded to about airway and breathing and sleeping. I had to go through all that with them to start to figure out that this girl was having a problem. Turns out she'd been to the ENT, had these other. So again, not to belabor that point, but yes, it is multifactorial. No one thing that an orthodontist is going to throw at this is going to solve all these airway problems, but taking the time to diagnose, determine the etiology, ask the right questions, and then put an action plan into place. So that I wanted to, again, recognize you for that point.
To say something that we making this for money, which I completely disagree, because I can tell you, for example, an adult patient has seen me maybe 3-4 months ago. And in a consultation, he said to me, can I record this? I said, I agreed to it. And I hear his speech, his lip speech, his nasal speech. And he said a class 3 bite. And then I just seen when he's speaking his severe anterior tongue tie. And then I started asking questions. Says, how's your sleep? And he said, I sleep maximum 3-4 hours a night. And I need sleep pills. I take antidepressants. Yeah. And I have ADHD medication, and I need a drink every night to fall asleep. After that, I stopped him. I said, listen, mate, I'm not the right guy right now that you'd help, because if you continue at your age of 38, the way you're living right now, your life with medication and drugs to fall asleep, you will not be here for very long.
Yep.
So you need help in terms of your breathing, your tongue tie, your tongue positioning, before you even consider coming back to me for any orthodontic intervention. He started crying and said, why did no one ever tell me that?
Right.
And I didn't earn a penny.
Right.
I sent him away, said, listen, this is what you need now. Do this first. And if you have done these steps, I'm really happy to do jaw surgery for you, because that's what you need right now. But I am not the right guy right now. I'm really scared for you in your life right now, because you cannot continue that way. So he really appreciated that. He was really emotional, said, listen, Steffen, you are amazing. Thank you so much. I will come back in time. I will get the thing sorted now. This alone changed his life already.
Changed his life. Yeah.
And I did nothing. All I offered him is education.
Right. Well, you did nothing treatment wise, but diagnostically, you did a ton for him.
Right. And so it's not about money. It's about the right thing to do. And to sum it up, if you know these things, Mike, you cannot ever unsee them again.
I absolutely agree with that. And I've never, I'll ask you if you have too, but personally, I'll say I've never met anybody who started doing what we're doing, right? What we've spent the show talking about, who was like, yeah, you know what? That really didn't end up working out. And I just didn't see the benefit. Conversely, I have had people who are like, how did I not know this? And if I had only known this before, I could have done better. Has that been your experience as well?
100%. Look what's happening in our consultation. You talk about the children consultation, but don't forget, every parent is sitting in the corner listening to you, self-assessing their own life.
Yeah.
Says, hold on a minute, Steffen. I have these symptoms. I went through this.
Right.
I had this. I actually need help.
Yeah.
So we didn't learn this today, and it's a long story. And yes, we need these emotions, we need these experience where we say, because we were scared as well when we first widened the palate, and then we thought this will work, does not work. But once you get this emotion, this feedback from your patients, you think, whoa, this is so powerful. I want to do
Yes.
more. I want to do more of
Yes.
this because this is the energy you need as an orthodontist to go back to work every day because wow, this feels so good. I never ever go through my daily list again thinking, oh God, what am I doing today? I think,
Right.
oh wow, who can I help today?
Yes, that's the reason I'm doing what I'm doing now, devoting this time and energy to teaching this. Because I literally, I had some situations where friends of mine that didn't live in my area sent me some case of some of their children's cases, and I saw this, as we've talked about through the show, that the young patient and the allergic shiners and the dark venous pooling and narrow arches and high vaulted palate and anterior crowding, say 6, 7, 8 years old. And they're like, oh, I know they knew an orthodontist. So like, would you mind taking a look at my kids' pictures? We took them to the orthodontist, and when you saw that, and they're like, yeah, they're telling us we need to start pulling some teeth, and that we shouldn't do anything until they're like 12. And I mean, after a couple of these, I started saying, I know I'm having an impact in my community locally, but we've got to start fighting for this on a bigger scale because it's just not happening in our schools yet. There are some people, Audrey Yoon, there's people out there who are doing a lot to really get this into some residency programs. But in America today, this isn't something that's really discussed in the vast majority of residencies. So we have some catch up to do. But it's the good news is that's the challenge ahead of us. The good news is that everybody that starts to do it, as you said, once you start doing it, and that is a hard hurdle to clear, right? It's not easy to question the way you've done things, to change, to implement that change, to face your staff and your patients and be like, yeah, the way I was doing this before, I actually am going to do this differently. All that's very difficult. That being said, as you said, once you see it and once you feel it and do it, you can't unsee it. And the emotions that it stirs in you as a human. And I really do believe as orthodontists and dentists and pediatric dentists, we all went into this to help patients, right? Make a nice living, of course. And we wanted to be in a profession respected in our communities. All of those things factor in. But if you didn't care about really helping people, I don't know that many people that have gone through all the time, energy, resources, and difficulties we all go through to get the degrees we get to do this. So that's the beautiful part about it is once people do it and you have a parent break down in tears or have a patient like that gentleman you spoke to who's, just gets emotional. Is like, I can't believe you took the time to listen. It impacts you. And it motivated me to do more of it. And then ultimately to go out and teach it.
Yeah, I mean, I couldn't add anything to that. This is why I do what I do nowadays, and I want to do more of it like yourself. Actually, like my clinical time is not enough value because I only help one or two patients. It's not good enough for me
Mm,
anymore.
mm,
We need to teach, we need to educate, and from a responsibility point, I'm very strict on it. As an orthodontist, I think this is our responsibility
mhm,
to help children, at least to screen them, to diagnose it. If you don't know what to do, go to refer to someone who can help.
mhm,
But this is our responsibility because if we go just down that route of AI and showing cartoons and moving adult teeth and ignoring the whole human being behind these cartoons,
mhm,
then we're going down a route which is very impersonal and we know already with our children in virtual reality, this is not life.
mhm,
It's much deeper than that. And we still need emotions. We
mhm,
cannot live in a virtual reality world, in this fake world with judgment and everything else. We need emotion. This is what it comes down to. We're lacking in this and more, our children as well. So we need to help them. And if you can't do it, get your education. We help you with that. yeah, if you know someone who can do it, refer to them, but at least screen them and offer them help. And that is my message I have for everyone. It's not that we're money orientated. We want to help children in this process because it gives us something I haven't had and never ever had in adult treatment. Never.
Yeah.
I
No.
mean, what I get from children, if it's just a hug or
Yeah.
a high five,
Yeah.
it doesn't matter. But like I had yesterday, a kid coming back with a cheesecake. She made me cheesecake, and it wasn't the best cheesecake, but it doesn't matter. You know,
Right.
it, it,
Right.
it came from the bottom of her heart
Yes.
to say thank you for
Yes. Or
listening.
even the way they jump up in the chair differently after a few visits, right? When they know you're helping them and they're over the sort of anxiety of this is new and the fear that
Oh,
they have,
it's so
just the
so good.
way they jump in that chair when they see you and they're proud. I mean, it is not as opposed to the adult. And I did a lot of great things with adults as you did, but they're not exactly jumping in the chair. They're like, how many more liners, or when are these things coming off? It's so
Why?
much
If
fun to treat
like
these
with
kids.
adults, you say if there's no complaint, you were good.
Yes, it was a good day. Yeah, a good visit.
It was good day, no complaint, good day. In
Yep.
kids, you don't even get a complaint.
No, no, you can tip them
It's
upside down. I mean, they're just, once they trust you and you have those systems in place in your practice to develop that trust, and they know you're helping them. They know it. Whether they can verbalize that or not is another thing. But they're just, the way they interact with you is so cool, and it's so much fun.
Yeah.
And I so appreciate you, what you're doing, the fight you're fighting, doing this while you're practicing, and being able to communicate this and your passion for this. That came through clearly to anybody. It's why I wanted to have you on. You don't just do this because you're just going through the motions as an orthodontist. You're doing this because you want to change these kids' lives, and you can. And that's the other thing I found. Once I knew I had the ability to do this, I really felt responsible to keep doing it and to teach others to do it. Because I'm like, I have figured something out and have been able to be blessed enough to be able to start to change these kids' lives. I can't sit on this. I've got to share this, and it's clear you feel the same way. So, is there anything else you want to add before we wrap up?
What I want to say, we can change the life of a child one breath at a time.
Love
So
it.
we need to, if we can do it, everyone else can do it. And I am, for any orthodontist who's out there who might be frustrated with their daily business of having the pressure of adults and everything like this, maybe think about it, how you feeling right now with all the pressure on you, and maybe feel how we're talking about our passion.
Mhm.
Maybe you can be in the same way by just maybe unlearn some things, learn new things, and getting the passion for this, because we got it, we
Mhm.
changed, so can anyone else. So it's up to you if you do it or not. We are here to help.
Love it. Dr. Steffen Decker, what an amazing conversation. Just your passion comes through, and so great talking with you. I really appreciate. Thank you so much for taking the time and for doing all that you do, and for all that you're working towards on this. I really appreciate you being with me today.
Thank you, Mike, for it was an honor to talk to you. It's just lovely to share this with someone on the other side of the pond. Thank you for the invite, and I hope we see you once in person together.
Yes, let's stay in touch. Absolutely, we have to continue to collaborate and work together to advance this mission. So thanks so much again. Really appreciate it.
Thank you. Have a nice
All
day.
right,
Take
you
care.
too. Bye.
Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.